get people to move to your seats fairly quickly. So we're very privileged today to have Professor Tien Wong visiting from Singapore. He's currently Vice Dean of the Clinical Sciences at Duke National University of Singapore Medical School. He's a medical director of the Singapore National Eye Research Center. He's done fellowships, retinal fellowships all over the US and Australia. He was professor of ophthalmology at Melbourne University. Now he's back in Singapore. And I think an important thing to say is that he has over 1,000 peer-reviewed publications and has raised over $50 million in research funding. And he's going to tell us today about things that we should pay more attention to, translational research in ophthalmology. And Tien.
Yeah. Thank you. Thanks very much. I think maybe first special thanks to Hannah for inviting me here. I think she was quite anxious today. I'm sure a lot of you heard that there were some delays in the planes. But I think the good news is that there's going to be a Singapore-Canberra flight direct, so maybe I'll be here another time that's easier, and I welcome all of you to go to Singapore. It'll be much easier for that. I'm very pleased to meet many old friends and colleagues and to be back in Canberra. I was in Australia, in Melbourne, in a very, I would say a very pivotal period of my life where I started off as a senior lecturer, progressing to associate professor and professor at the University of Melbourne, and we had a very good foundation here. And I think one of the interesting things was that, I was asked to share some of the Singapore National Eye Centre experience. And much of those experience, I would say, I've kind of learned from Australia. And I would say that Australia provides a significant and strong foundation for translational research. So I won't say that it is really, me so much as sharing some lessons, as sharing lessons not just from Singapore, but really also from Australia, and maybe some pointers that will allow all of us to do more translational research in the future. I've kind of mentioned University of Melbourne, and that's Gerald Crock there, and he was the first Australian professor of ophthalmology. In fact, the Department of Ophthalmology is the first in the whole outside of United Kingdom. It started 60, 70 years ago when Professor Crock started the department. And Hugh Taylor, I'm sure a lot of you, particularly those in the visual science and ophthalmology world, will realize that he has played a very significant part in this career. And I think that, as I said, a lot of what I'm going to share probably are lessons from not just Singapore, but also from Australia. Now, what I'm going to do for the next 15 minutes or so is for you to sit back and just, I think, just maybe perhaps enjoy some of the things that I put together. There's a lot of pictures, a lot of, I think, observations, more than hard science that you have been hearing this morning, about mRNA and AMD and so forth. I'm going to give you a little bit of sense of what Singapore's Biomedical Science Initiative was, and you might have heard a little bit about that, and I think that it's good to understand a little bit of perspective from there. Background from the Singapore National Eye Centre, and therefore maybe some relevance for how a small unit or a small department can grow, whether it's in Canberra or other parts of Australia. And three simple stories of what I think are translational research that will help us understand some of the principles of doing that. And then observations I will share at the end about what I think are important areas for us to do translational research. So let me get started with the first overview of this, right? Last year we celebrated the 50th year of Singapore's independence, and there was a lot of thought about, the first 50 years is tough, but it seems like the next 50 years is going to be harder, because one of the whole problem about Singapore is this thing, right, that there's this uncertainty that it should really exist. There is, as a lot of you, I'm sure, might have either passed through or gone to Singapore, would realize, it is It's a very small little island. There's no natural resources. There's been always talk that Malaysia, for example, in working with Singapore, and in some of the disputes, have always said, why don't we just shut the water off and that's the end of Singapore? It's that kind of threat that Singapore always lives in, essentially, right? And so Singapore really thrives in this kind of atmosphere, right, of being irrelevant to the world because it's a small city. And I think maybe sometimes Australia, to a lesser extent, right, because you are in the further part of the global world, part of Asia, part of the Western world, very difficult and far to get to, that kind of thing. So I think sometimes Australia also thrives on that. And Australia has done well on many aspects, including biomedical research, as you are quite aware of. But I think for Singapore, it's the fear of irrelevance, right? Because, any time that someone says, and Indonesian has said that of us, you're a small little red dot, what can you do? We ignore you, essentially. And because of that, it has always had what we call a very deliberate growth strategy. Nothing is planned. Nothing's unplanned. It didn't get into biomedical research because, there were people doing PhDs interested in developing a research, right? But it really did what it called a sustained 20-year multi-phase planning, right? And this was the biomedical research plan. And maybe some bigger countries like Australia has a little bit more luxury to not need that kind of planning because, you have many different natural resources, you have many different propositions that Australia has. But Singapore doesn't have that kind of capability. So when in the 1990s, when Singapore realized that trade and manufacturing is going to go to first China, and then now it's going to go to Vietnam and Cambodia. It's not even going to China anymore, right? So it was going to lose manufacturing. It went into a few thinking behind it, right? One was finance, and you are aware that they tried to build a banking sector and so forth. The second was this biomedical science, right? And I think at that time, thinking was, let's start with, a very ambitious plan. And they sent, and the number was banded at 1,000, probably is a correct number, right? 1,000 people that were sent to the best universities around the world. We'll attract them at high school, get them to do a PhD at Harvard and Cambridge and so forth, and start a foundation for basic biomedical science, and had very generous scholarships, and each could be in the region of $500,000 to $1 million, right? That's the kind of investments that you're looking at. And so they started building basic science foundation. And then second phase, they thought that you need a bit more translational, and they started investing into grants that were very programmatic. So a lot of the grants in in Singapore was less bottoms, like the normal NHMRC kind of project grant, right? It was more programmatic grant, essentially, right? So it says we want to focus on 5 disease areas, and we wanted to focus on areas where it required a basic science and the clinical science department to come together. And then it needed industry partnership. That means some industry, pharmaceutical company was interested in the outcome of that kind of thing. So that was the second and third phase. And then we are now in the fourth phase of this kind of initiative, right? Where they are really looking at outcomes. And a lot of hard questions has been asked, what's the return on investment? I'm not sure in Australia, in one sense, we have been asked that kind of questions as much. Sometimes it's been banded on, but I think biomedical science, in one sense, in Australia, is more foundational, right? It is the culture and the nature of our education system in Australia. And it is part of us, it's part of our development, essentially. Whereas in Singapore, it's less of that thing. And I would say that maybe it's not such a, it has good points, but it has its own challenges and limitations. And because of that, some limitations started coming in, right? So by about mid-2000s, challenges started coming in. So this Australia is the same as Singapore, right? And this article on the right-hand side here was in the front page of the Straits Times, which is like the Australian or the Age or the so-called the major newspaper, right? And it started and this is the first time, right? Can you imagine? I mean, Singapore patients has to be intense. I mean, you can't imagine that those of you who've gone to Changi Airport saying, how can there be tense? Why were patients intense? That kind of thing. So it started because there's many historical significance about Singapore, why, it kind of didn't catch up with this whole idea that the aging populations plus immigration was a significant strain, right, to healthcare resources. It's no different from what I'm sure you are understanding in Australia and many countries, right? Because it is not actual numbers of growth. It's the fact that people are living longer, that there's exponential growth, right? So one person that is in the 90s, for example, which is very common in Singapore as in Australia, needs 4 doctors, or maybe 5 doctors, maybe even 10 doctors, right? Rather than 1 doctor. So it's a very different thing. So anyway, it's faced challenges because the hospitals were now saying, hey, research is, what has research got to do with us? It's a little bit like here, outside this auditorium. Some of the nurses and the doctors are saying, we are busy, right? Why are you doing research in our setting? We are barely able to keep up with this. So we're starting to have some challenges, and we needed to address some of those things, right? And of course, it was easy to say, let's build basic science. You can fund 1,000 PhD students and so forth, and then you can fund labs. And if you have gone to Singapore, you will find the equivalent of what they were trying to build, right? A biopolis, right? It was an entire complex, 20, 30 state-of-the-art buildings, right? Almost equivalent to NIH kind of setting. And again, I'll encourage you to take a look at it. It's really a feat by itself, right? One of the buildings is named Genome, and one is named Proteome. That kind of significance. A huge, colossal building, and they hired many people. A lot of Australians actually, in search for funding, came to Singapore because of this thing. But they then found that it was easy to build a phase 1, and phase 2 was when you started saying, I need it in the hospital, I need the clinicians to do it, I need to do that, and you found that it was not so simple to do that, essentially, right? And it found that you can't plan it, and you can't do this thing. So that was the second, I think, challenge that happened. And then the third thing was this whole idea that you need physician scientists. I suppose my own career would be categorized as a physician scientist. Most doctors don't think of themselves like that, but those that are interested in research, spending, whether it's 30, 40, 50, and some spend most of the time on research, will consider themselves in that category. But it's not easy, essentially, right? Because, you face all the different challenges, particularly for physician, essentially, right? There are all, there's dual training you need and so forth, essentially. So it's not that easy, but I think that you do need this kind of thing. So actually it was not straightforward for Singapore to move on. Now, so have we addressed a lot of this? And I will go back to this whole aspects a little bit later when I talk to you a little bit about what I think are important on how we try to address it, at least at some of the campus level activities, because some of them needs a broad policy level initiative. I'm going to switch tack a little bit to talk to you about SNEC, which is ophthalmology, which is eye, and give you a little bit of background because you may not know a bit about this, about SNEC, and then kind of like draw you back onto, how did we, meeting these challenges, that was faced by Singapore globally, how do we address some of this, right? So the first thing is, this is SNEC. It's, in one sense, kind of similar to the Royal Victorian Eye and Ear Hospital. For those of you who have gone to Melbourne, you would see a similar kind of structure, probably 2 or 3 times bigger than the Sydney Eye Hospital, which is a smaller kind of setup, but the size, equivalent of the Royal Victorian Eye and Ear Hospital. So, 1,000 people, 60 plus clinical faculty, and so on and so forth, right, essentially, right? So there's nothing particular about an eye hospital. There's several around the world, right? I think what we have tried to do, number one, was to be very clear, and this is the lobby, the foyer, so the entrance of the hospital, right, where we put at the center of our lobby so that the patients, the doctors, the residents, the nurses, they see this all the time, right? That there is a component of care which is important, but that there is research and there's teaching. I think they go hand in hand. And then there's some thing that we think is important for the service, the community inside there. So I think that this is something that we at SNEC have always kind of suggested we have that mission. And it's not that simple, because for many different hospitals, as I said, the hospitals were really focused on clinical care, rightfully so, essentially, because of limited resources. But if you want to do translational research, you do need to get everyone kind of bought into that mission, essentially. Now, across the road, so facing this building is the Singapore Eye Research Institute, and it is a large research institute by any standards, whether it's the size or the amount of grant funding they have in the region of their budget is about 20-30 million a year, and many different research groups with many different PIs. And so I think, you know, it's no different, again, from a big eye research institute. You know, even in Canberra, in ANU, and so forth, you have this kind of thing. So what were some of the key points about this? So let me take a step back about when it started, right? Because I think the history will give us a bit of sense of how we've kind of got to where we are at. So this is the site of the SNEC, and you know, it's an old picture, but it's a department within a big hospital, the Singapore General Hospital, and there was a wing that was given to it. And it's no different from that part. But when it started thinking about this, we formulated in the 1980s a national eye center to kind of gather all the resources, and now we have about half of the ophthalmologists in Singapore that's working there. And at the opening, Arthur Lim is one of the, I would say, the founding fathers of ophthalmology, not just in Singapore, but he's done a lot of work in the Asia-Pacific region. But I think when he started this whole concept, and that it's 1991, remember that this was even before the Biomedical Science Initiative. We said that we started about the 2000s, essentially. So even at that time, because he's visited many places and so forth, he suggested in the opening of having the National Center that you should have teaching and research as part of the culture. And because of that, about 10 years later, they built what we call a research clinic, you know, this entire floor, an entire floor in the hospital that started the research institute that allowed patients to be recruited for clinical trials, separate from any of the clinical facilities around there, right? And at that time it was quite unique, and now it would be quite impossible, actually, because the hospital would say, you know, you have a big, huge clinic space, shouldn't they be used for normal clinical care, right? But now it's being protected because it was a site of where we did a lot of the trials. And at some stage over the past few years, we've been doing, you know, at any one time between 30 to 50 clinical trials at any point in time, right? Because it allowed the nurses, the technicians, the doctors, and the patients to feel that they were being able to be recruited from a normal clinic into a research clinic that allowed actually much better quality care, as well as patient consent and all the things that you need, rather than having patients, right, in the research patients in the clinic. And we couldn't do that in eye and ear hospital, so that's one of the things that we found very difficult to do. And as I said, if you didn't start it, it's very difficult to now say to a hospital and say, look, I need this entire space for a research clinic. It's quite difficult to kind of engineer. But it started at that time, and so I think it was very successful from that point of view, right? The other thing that started in Singapore, and I think that in Australia is much more established, right, was a partnership with university, essentially, right? So partnership with NUS, and develop what we call academic lines, essentially. So for clinicians that wanted to do research, they could get some of the academic credentials, protected time, the promotions, and the academic titles that came along with it. Was very pioneering at the time in 2003, because most hospitals, you know, you had a hospital system. I think in ANU, in Canberra hospitals, you don't have that kind of situation very much, but and in Australia it's much more widely accepted. But in Singapore, that wasn't the case, essentially. And we also went to do a significant partnership with another institute. This is in Duke, and we started having a partnership with Duke Eye Center in about 2010 under the NUS umbrella. And the reason why we did this was we felt, just like Duke, that they want to be a global player. Right? Duke was very focused on US, right? It's in North Carolina. It does good work, but it had no foothold over the other parts of the world. And Singapore, in that sense, where they was trying to think about more global aspirations, wanted to have a partnership with someone in the US, essentially, for that matter. And it was very important, I think, when you're looking at these partnerships, to look for partners that were of very similar size and capabilities. Duke had about 70 ophthalmologists and a similar size research, a little bit different focus areas, but very well equal and in matching. In fact, we went to look at Hopkins and so forth, and there was mass eye and ear, and I would say that there was more hubris that you can imagine from Harvard and so forth, essentially, right? Whereas Duke was much more down to earth, and they really was very keen about that partnership, and so that has started this partnership. Now let's go into SNEC and SERI and look a little bit at our track records, because I think that also gives a bit of sense of where we are at, right? So this is over time we have done well, I think, by a lot of traditional standards, 2,000 papers over the 20-year period, so about 100 a year, essentially, right? And we have a very strong vision to try to aim high, and we publish just like other institutes on some of the bigger journals looking at that. But also we were very keen about understanding where the competition were, right? And so this is here, and you can see Moorfields, Hopkins, Harvard, the big players on the on the landscape, and then we've also kind of, as I said, you can see Duke and SNEC are quite measured in one sense. This is just one parameter, but we felt that there was a lot of compatibility there, and therefore we partnered with them on this kind of journey. And some of those are validating some of the Singapore's competitive edge. And actually Australia does a lot of this, right? I mean, you know that you have one of the highest number of, for example, Olympic medalists per capita, right? As you know, I'm sure you're getting a few more as we speak, and hopefully, essentially, same thing, whether it's sports or in Nobel Prize and so forth, because because by size of the population, Australia is probably 30 times smaller than US and so forth. But so Singapore was doing well for number of papers published. This is 2008, and we had another recent paper that came out on 2016 on papers that's published. And quite interesting again, essentially, right? If you look at this, right, this is looking now at quality a little bit more. Cumulative 5-year impact factor. That means they look at number of papers times the impact factor of the paper that was published. And of course, no surprise, US was there. Of course, they made a note that China over the last few years has just gone up the roof. Australia obviously is here, and Singapore is just at the bottom of this thing here, right? But if you look at, of course, things like per capita, then Singapore goes up here. Iceland has 300,000 people, so it's done well, obviously, essentially, but and it's done well for 300,000. And then they kind of adjusted for the GDP, and Malawi actually, and Guatemala, it seems like they do well. But anyway, I think it's just a sense of where they are at. But I think more important is a little bit of this thing here, right? They divided this is the mean impact factor of each paper, right? And IOVS is in the 3.6 or 3.5 range, ophthalmology is 6, and so forth. And you look at that, I think Singapore has done fairly well, right? 3.59. So it's a fairly, it's publishing not just quantity, but each paper is of maybe an IOVS standard, something of that sort, and a little bit quite similar to US, and maybe similar to the Netherlands here and so forth. So I think we have thought about it, and we thought, it's been quite a good investment in terms of what we have been looking at there. We've also been able to think very carefully about clinical impact of our research. And last year, when we celebrated 25 years of anniversary, we trod through all the 2,000 papers, and we thought that there were some that had clinical impact, and we've kind of like looked at this. And we also are now starting to think a little bit about commercialization of innovations, right? And so, where each technology is, are they very late stage or are they not? And I will talk a little bit about atropine, which is one of the examples, and I'll talk a bit about retinal imaging, which is another example that is a lot of my research. Okay, so that's the Singapore experience and the Singapore biomedical science and where SNEC sits. So I'm going to go a little bit deeper into, I would say, 3 simple stories about what we, how we have done some of these kind of translational research. I think the first is myopia. Now, I was expecting a lot of general audience, but I'm sure a lot of you knows this now. I'm sure a lot of my colleagues here at least knows this quite easily, right? But anyway, myopia, is a problem where there's excessive growth in the eyeball due to many different factors. But nevertheless, generally it's been thought that you need glasses or contact lens, or if you are keen, you can do a refractive surgery, LASIK, and you can correct for that essentially, right? And along with a lot of colleagues with Brian Holden's group and so forth, we've looked at the number of people with myopia, and actually it's a significant problem. It is probably the biggest problem, depending on what you consider it as a problem or not, right? I mean, is it a problem like AMD or diabetic retinopathy, or is it just a condition that we are thinking about? But basically, we're talking about, a lot of people, many people will have myopia, not unsurprising, right? And so, in one sense, it is a big problem, right? And we are now looking at it, not just the number of people with that, but as they age, they start getting a lot of these conditions, the degeneration. Some of them are very similar to AMD in one sense, but you have an aging component on top of what is, I think, a stressed eyeball situation at young, right? And therefore, you're going to get into a lot of this problem. In fact, a lot of our patients are now getting into this kind of situation itself. Now, why did I talk a little bit about this? Because Singapore has one of the highest prevalence of myopia globally, right? And I show this picture because, Singapore boys all have to do this military service as part of their 2 years, essentially. In fact, this is my son here doing this. He said that he's not allowed to show this picture because it's classified. But most of them are training in, they're training in Queensland anyway, so, why? Yeah, so, But anyway, okay, so I'm just pointing out that, this is, what the problem is, right? In fact, there's some pockets of, we had difficulties finding pilots, because there was, you need almost emmetropia to have pilots. So early on, in the 1990s, right, a lot of the problem of myopia was from the military perspective, right? And so people like Benjamin Seed and Lionel Lee were the chief medical officer in the military and thinking, we need to solve this problem. I know a lot of people are not interested, particularly early on in the 1980s. No one's interested in myopia, but Singapore thought that they wanted to, and therefore they started what we call a whole series of research there, right? And a series of randomized trials, right? Early on, looking at full dose atropine, and then looking at trials that was looking at very low doses, 0.1% dose of atropine, and then now we're going into kids, not just progression, but in those with high-risk kids. So in other words, where they have family history, both parents are myopic and so forth, we are starting on those trials. But basically, we have started a very series of this very concerted attempt that we have even developed, an eye drop that is now used as SNEC, and because there's no patent involved for atropine itself, people can make it, and so Taiwan has it, and Japan is interested in it. A lot of China is interested in that, and so I think that that was one of the very, I would say, over a 15-20 year period, one of the success in us looking at that. And then we also looked at a very important look at emphasis on patient and society. We always have patients at the front facing of a lot of our media and interviews. This is one of the participants of the trial itself. We've always calculated, put some cost-effective analysis inside so that the government understands that, of the impact of what we're looking at, so this is the cost of savings per year. It was given to, 20% of the children, right? A very low estimate of this. So I think that's how we've kind of looked at that. So that's one, I would say, simple way story itself. And the lesson of that story probably is the fact that you need some partners, you engage into a problem that is very unique to your country, that people are interested in the outcome, and that the partnership with the community is very significant, because it was very easy to recruit patients for the trials. It was almost a one advertisement. In fact, we have parents calling in to say, it's a trial, have you stopped recruiting, can we enroll our kids, and so forth. So it was a very easy for us to do that study, but because of the high public awareness. Now I'm going to switch to diabetic retinopathy. And diabetic retinopathy is a big problem. As you know, these are the number of people with diabetes. We're talking about maybe 380 million, maybe 500 million people in the next few years or so. And I won't go into diabetic retinopathy. As I said, I think you understand what they are, but it is a common complication affecting the small blood vessels, and early on you get leakage, and then the vessels close and you get ischemia. And of course, because it is asymptomatic early on, many studies have shown that it is cost effective to do screening, right, essentially, right? So this is an example of a mild diabetic retinopathy patients that's asymptomatic. You don't need to do anything for these patients. And when they start to get a little bit more severe, you can see some more hemorrhages and some cotton wool spots over there, suggesting that there's a little bit more ischemia, still asymptomatic in these patients. And then when they start having new blood vessels and these leak into the vitreous cavity itself, and then you can have very advanced disease, and therefore you will lose vision, right? So that's quite clear, right? So patients like this will typically need laser treatment, and this is what laser treatment would look like, which is, which actually destroys a large part of the retina, or they are now increasingly, a lot of them have this injections that is very common, and I'm sure a lot of you have heard about this for AMD and so forth. But diabetic retinopathy screening for a long time has been recommended, as a national kind of a way to stop this, because a lot of us ophthalmologists are very keen about looking at this. But really, if you want to prevent diabetic retinopathy, you need to screen at that stage there and only refer those that looked into this. In fact, the clinical guidelines suggested that we need screening right from the 2000s when we started looking at the prevalence of diabetic retinopathy. This is the Singapore Clinical Practice Guideline in 2004. This is the Australian NHMRC guidelines that was in 2008, essentially, right? And so they said you should have a diabetic retinopathy screening program now. So you have good research, you know that it's cost effective, you know you're going to benefit millions of people, so why isn't that done, essentially, right? So that's one of the big questions that we looked at. So when we started, and I'll tell you a little bit about the Australian story in a second, right? So when we started this program in probably the late 2000s, essentially, almost 5-6 years after the guidelines came up, we were not very optimistic, because it took a lot of bureaucratic hurdles, a lot of meetings, and a lot of unfunded time, essentially, because no one will fund you to do these kind of projects. You almost need to do it on your own, I think, as part of your operations, essentially. But basically, we set up a screening program where we thought that we would screen 100 to 120,000 people in 18 clinics in Singapore, right, across Singapore. So maybe it can be done in Canberra. You have about 1 million population. You probably have, 100,000 people with diabetes, right? Roughly in that region, essentially, right? And we took photographs, sent them to reading centers using IT platforms, and had them read and sent back, essentially. And those that need referral are then referred on to their patients. So a very simple concept. So I'll just show you what it means, right? So these are the 18 polyclinics, the clinics, primary care clinics, right? So the nurse started to get trained to take a photograph, The photographs are taken, are sent to reading center. We have 2 reading center so that there is some ability to kind of compare results and so forth, and also some ability to test different types of systems in quality improvements. And the report that's from the reading center are sent back to the same clinic, where the physician can then talk to the patient to say, you are fine, you can come back in a year's time, or you need to go to specialist clinics across Singapore, right? So that's the idea. This is what it looks like. This is the system of, of what the right and left eye assessment was done. The photographs are brought up, and then there's a report that is on a PDF form and sent to the patient and the physician. So, it looks simple, but to try to do it, took probably a good part of 5 years, essentially, to set up this system. And I thought that was long, right? When I spoke to other people in the UK, which has the other big national diabetic retinopathy screening program, they took about 10 years, essentially. And of course, it's a bigger country and a lot more, regional and national type of a system and so forth, right? And this is the type of numbers that we're now seeing. So this year, we are projecting to hit our target 112,000 quite soon, and it has started. And what it has done is that we have built a very good case for it, essentially, right? And early on, it wasn't that simple. It has reduced a lot of the reading time because the system pushes the images to the reading center. So the person at the reading center doesn't need to call up, it's all automatic, right? So the camera, once it's taken, it goes to reading center, there's a queue, and there's a whole bunch of readers that reads it, and there's a master reader that kind of like shuffles the queue around, essentially, so quite automatic. And in the past, it used to be that there were cameras around, many places have cameras. In fact, Australia has many clinics that has cameras, but who's going to read it? You're going to get either the GP to read it or the optometrist to read it, and then they read it at all sorts of time, lunchtime, after hours, and sometimes it's delayed sending it back. It's like writing a medical report. We all hate to write it, right, as physicians. You understand what I'm talking about for this thing, right? So, and then we are able to build scalability of that, and then there was standardized grading criteria. And once the system was set up, we could introduce patients that were so-called fake patients, essentially, right? So that there's an internal audit, so that the readers were reading patients that already was not in the system, but it could give some quality assurance and quality monitoring process. And then now some of the bigger companies are interested in this for machine learning and so forth. So Google has approached us, IBM, Watson, and so forth, because they're all interested in these big data and so forth. And I think that the initial results suggest that they probably can do a better job than the readers. So I can imagine that over time, you're not going to have readers reading it, but some machine learning algorithm is going to separate that out between those that needs referral and not referral, right? But I showed this thing here because of 2 things, right? The people that was with me that spent time doing this thing that now is in place in the 18 polyclinics had one big problem for them. Over this 5 years, they had not a single publication. Right? So, if you want to translate research in one sense, you need to start thinking, is it for, what's the outcome? In one sense, that will have a major impact on preventing vision loss in people with diabetes. But does it come out with the measure that you're always interested in? If you have some research fellow that's with you and they're working on this, almost no papers. We're going to come out with our first paper after this 5 years, right? Basically looking at the cost effectiveness of the system. But early on, it was a lot of meetings. It was a lot of dealing with bureaucrats. And then after that, the bureaucrats will have changed. Ministers of health changed in between. And so there was another 6 months delay and so forth, right? And it was the same thing, right? So this is 2001, right, when it was in Australia, when a lot of Australians, put together a paper to get Medicare funding for screening for people with diabetes, right? I remember this document that's sitting on my computer somewhere, right? And then it's 2008 with another draft that goes in 7 years later. And I can show you all the various emails that they said that, it's election time. happens quite frequently, unfortunately, in Australia. So, I think, and then you have change of things, but anyway, right, I think we are all in luck because I think it's now scheduled as a Medicare item. But what are we talking about? 2001 and 2016, 2017, right? So in one sense, I think this kind of translation of results, research that is done around the world, a lot of it done in Australia, showing the prevalence of retinopathy, so many articles written in every journal that you can think about, right, in Australia about the problems in underserved community, people getting still blind from diabetic retinopathy because they have not seen anyone there. There's no system in place for this, right? But it takes 16 years to translate that research, and I think that's useful lesson because it takes time, but it will get there. And I think that if you don't start on it, you will still not see the results of this over time. But I think Australia will get there, just like Singapore has over time. And I think we've been very proud of this, and as I said, I've done my time in Australia, and I still can't see it from that time, and now it will happen. So I'm very pleased that this has happened. Now I'm going to go into a very aspect that I've built a lot of my kind of research track record on, right? And this whole idea and what are the things that I think are, again, also quite important in this. And this is this whole idea that maybe you can look at the eye and look at the vessels and try to tell you something about vascular risk, right? Very simple and elegant concept, right? And I think when we started off this whole journey, we spoke to people that were interested in vascular risk assessment, basically cardiologists, stroke neurologists, and so forth. So we asked them, what are you interested in? What are the 5 or 6 most important questions that you want to deal with? So you start from that end. And one of those people, very persistent early on, are saying that, we really don't know how to differentiate and to measure microvascular pathways. So I think that's a very important part. So they thought that maybe half of the stroke was caused by small blood vessels. In other words, you could have normal carotids and you're going to get a stroke, right? You scan your carotids, it's fine, there's no macrovascular disease, big vessel disease, and yet you're at risk of stroke. How do you assess that microvascular pathway? So that was a very important aspect. And that's how we started this work, right? And then how do you precisely identify people at risk? And for those that already have it, how do you predict a prognosis, essentially? Because a lot of people with one stroke do not know whether they're going to get another stroke or they're going to get a myocardial infarction. I mean, the way we treat everybody. We kind of monitor everybody, but we don't really know. And then I think, how do we get better treatment? So I think these were big questions that they asked. And so when we started thinking about this, when we went back to how this whole idea came about, in fact, it started very long ago, right? Marcus Gunn and for those of you who are physicians will understand Marcus Gunn is a very famous physician that described the pupil, right, of the Marcus Gunn pupil, but many different signs as well. But basically, I think in the early 1890s, right, you can see, right, they started seeing that, patients that had very severe vascular disease, things were, it's stroke and so forth, they had signs in the eye. And so we started, therefore, thinking whether or not this whole idea of retinovascular imaging might allow us to study the microcirculation that will, therefore, allow us to understand some of the processes that went on. So over the last 16 years, what we have done was that we've developed the technology, and we've worked with many engineers and so forth to look at the vasculature itself. We've applied this technology to population and clinical studies, many Australian studies, including some in Canberra itself. And then, therefore, thinking about what does it mean for many different diseases itself, and then now looking at very different subgroups of patients that might benefit from this type of imaging, and then translation and ongoing. And so the first was to develop this software. How do you measure the vessel diameter? We developed this software with some scientists from US in the beginning, and then this was the original kind of software, and then it became a bit more automated, and this is the version 3, and the last version now seems like much better at tracing the vessels and looking at the different types of patterns itself. So not just one single measurement, but looking at how optimal the vasculature is of the eye. And some people are now really thinking whether we should use, again, machine learning algorithms, right? You don't need to draw it, or you don't need to identify what's wrong with it. Let the machine kind of like identify what's wrong with it from differentiating normals and abnormals. And these are all new computer software. And we've started in the 2000 with many US studies. We've gotten Blue Mountain's eye study involved in 2002, the OSDIAP study, and then some other studies like such as the Dunedin birth cohort study in New Zealand, and many different studies were involved in using this technology, right? And so we have many different experiences, and these are the sites that have kind of like used it all around the world. So once we've done this, we need to start thinking, what's the impact? What does it really tell us, essentially, right? So the first was that it really allowed us at first where we started looking at microcirculation. So many of the people looking at microcirculation had to do very invasive type of assessment. How do you assess the microvasculature? You either do a biopsy of the skin or other kinds of devices, essentially. So I think this whole idea that you could non-invasively look at the small blood vessels became quite exciting for people working in this field. And then, of course, we've also done this particularly for stroke. So this is a study with Richard Lindley in Sydney, as well as other collaborators, and then looking at Alzheimer's disease, and it was seen to be kind of like almost a biopsy of the brain vasculature, and so we were very excited about that. And then other people like Richie Poulton from New Zealand started applying it to his birth cohort, and they found very interesting association. For example, in this study, they've shown that some of the, I think, young adults that had early symptoms or signs, tendency of schizophrenia already had abnormal blood vasculature, so suggesting that maybe it's kind of like telling you a little bit about the etiology of schizophrenia, essentially. And then we've also, as I said, looked at some machine learning algorithms. So this is a patient with a stroke. You can see some of the changes that's there, and this is a normal patient, and some of the machine learning is able to pick up those kind of algorithms. It was useful as a model to study hypertension because for the first time we could quantify the diameter, right? This is arterioles. You can see the diameter is smaller than this artery here, and it was a very important sign, and we all learn as medical students that you narrow blood vessels, it's a bad sign, but how narrow is narrow, right? Just knowing blood pressure wasn't good enough. So it was very useful for hypertensive researchers itself, right? And then we started thinking, could it help with things like a drug trial, right? So a typical stroke or cardiovascular drug trial will be 10 years, thousands of patients, and maybe this kind of technology would reduce the time for looking at treatments, maybe the sample size, maybe the cost. And in fact, we have some of the other people around the world have looked at different blood pressure drugs on a smaller scale, essentially, looking at the retinal vascular improvement and the differential improvement rather than saying, let's look at outcomes 10 years later. And as I said, we've started doing some studies here, Rowan and others on looking at it for dementia, essentially, and that's some of the papers that's going to come up quite soon and for other projects. And then I think one of the things is that should these kind of things be used to measure hypertensive damage? Is it useful clinically? I think we are still in discussion with various groups. It's not straightforward for that, and I don't have enough time to tell you how a biomarker moves from being useful in a research setting to a clinical practice where the physicians use it, because it does require multi-stage proof of that kind of concept for it to be useful from that things. So I'm going to finish the last few minutes or so just to give you a little bit of observations, as I said, about what I think are ingredients for us to do good translational research, right? I think the first is that you need to look at programs that meets the needs of the population, the government, the situation, the setting that you're in. I think that's important. There's no point, we've been asked before, right? Some people wanted to do malaria research in Singapore. there's no malaria in Singapore, unfortunately, right? So I'm not sure that, it's that particularly important to the Singapore government. So I think that that's one of the things that, we have to think a little bit about. I think the second is what I would like to see happen a bit more, research in the clinical hospital environment, even if it is just simply having a research culture in the hospital, I think changes the way the hospital works and how researchers work, because I think that interaction is quite important. And then the last thing is what we have done about clinician scientists. Remember, at the beginning of the talk, I said how difficult it is to have physician scientists and to train clinician scientists, and I'll share with you a little bit about this. So as I said, we kind of like need to look at aligning ourselves to national priorities, look at the gaps, address things like myopia, which was quite important, and then a little bit about the competitive advantages that Singapore had, right? And so, the minister recently declared war on diabetes, and we kind of like jumped onto the bandwagon, put in several grants on diabetes, and I think that it will be funded, from that perspective. So I think it's the same kind of principle. Look at what your politicians and what the country needs, whether it's aging or dementia or other things. We've focused a lot of our attention on angle closure glaucoma. Angle closure glaucoma is a type of glaucoma more likely to affect Chinese and East Asians, and not as common as in other parts of the world. And when we started doing this research for many years, we've started, really building a track record there, right? So Singapore can't be the best in everything, and it really needs to select very selectively what it was capable of doing. And because of that, I think starting to see some of those results, right? So this is Singapore National Eye Centre, Singapore, for a particularly angle closure glaucoma. Not all glaucoma. All glaucoma, we will not be, it will still be done mostly in the, US, UK, Australia, and so forth. But for angle closure glaucoma, we are the leading aspects of that there, and I think that's important for us. And the second of it is this whole idea of, having a culture in the hospitals that is not just focused on purely clinical service, to one that I think embraces this academic medicine concept, right? And I think the Canberra setting where you're having the meeting here in a hospital, I think is useful. I have seen too many places where the research and the university and the research labs do not come together as often as they should, and that becomes difficult. And so in SNEC, we've kind of like have this whole idea of a research institute and a university setting within the same campus, and that has allowed us to do this thing. And in fact, actually, Melbourne was also one of the models, right, where the Centre for Eye Research Australia with the university in an eye and ear hospital provided a little bit of that kind of milieu for us to do good work, and I would encourage us to kind of look at that. I think it allows us to think about patient care, and it creates a good positive cycle, right, from research with visibility, and the visibility leads to attracting good doctors that gives good clinical care, and therefore you continue to have, build capacity in that thing. And in a lot of our settings, we are very keen about engaging with a lot of our patients so that they understand that coming to an academic medical center involves participating in trials and so forth. And I think that kind of culture will facilitate the translational research. And the patients therefore expect it. They will ask the doctors about it. They will pressurize some of their politicians and MPs to fund those kind of research. I think those are important things. Now, this is how clinician scientists develops in Singapore, right? 15 to 20 years, no different from Australia. After training, specialist training, and so forth. And these are the schemes that gets them on the different awards. So in Australia, it will be like the NHMRC Clinician Practitioner Fellowship along those stages. But we have supplemented it with many different things, right? So different types of pilot awards. Some of them are philanthropy. The Koo family gave us substantial money because they were grateful patients, and we started building a little bit of the philanthropy culture, and I think that's quite important from that particular aspect. And they funded pilot awards, clinical scholars, and so forth, so that it supplements what the national level grant funding, which can only fund really 10, 15, 20% of your best people, not everybody, essentially. And then we started within the hospital an academic medicine research institute that look at talent development, look at providing quantitative science, so biostatistics, epidemiology support, health service implementation support, and looking at helping getting medical writing and other things. And therefore, things like this kind of happens, right? This is one of our consultants now and joined our program and had different types of some are national level grant, and then some are the kind of hospital funded grants that allows him or her to develop. So I'm going to finish by saying that I'm again very grateful to come back here to share all this. I hope has been an interesting and useful talk for you. This is in the Australian Financial Review many years ago, and when we did some of the work here, and many of my work, personal work, in fact, was done in Australia. I think Australia, it has a fantastic environment. I've seen a lot of young students present work here. I think you will do well, and you are really in really a lucky country, right? I mean, that's what a lot of people outside Australia always say about Australia. And of course, it won't have happened without a lot of people that have come by my team, and some of them I'm still working with over all these years, and many thanks to all of them. They're not in this room, but obviously most of them are spread out across the different parts of Australia. So thanks very much once again for this ability to at least come here on a short visit, but to share with you some perspective about what we think is useful as a way of translating research, and what are the challenges of that. Thanks very much once again.
Thanks very much. Are there any questions? Is there one there?
Yeah.
Yes, sorry.
Thank you so much for a very inspiring talk. I think that you have many lessons to teach us. And, I can see a lot of those lessons being learned, actually.
Yeah.
I work in orthopedic research, so distant, sort of.
Yeah.
But I am interested in your ability to be able to pick up patterns in the eye that reflect systemic systems, the systemic system. And I'm wondering whether, looking into the eye, have you done any work on looking at potentially valvular disease in the lower limbs?
Not so much, but there has been some thought that is related to rheumatoid arthritis and so forth. In fact, we've worked with some clinicians on that because there's an inflammatory component, and therefore there's systemic inflammation. And actually the vessels in the eye are very sensitive to systemic inflammation, actually. So it shows. But less so of, let's say, osteoarthritis or some of the more degenerative conditions. I think the blood vessels in the eye are very useful as a measure of vascular health. Less so if it is just, as I said, degeneration. I think you need to look at other markers. And actually, we are thinking about that because in the Alzheimer's disease field, which I didn't have much time, there's been a lot of thinking and thought about measuring some of the layers in the nerve fiber layer that you can measure. So it's not just the vessels that you're interested in, but actually the ganglion cell layers and the retinal nerve fiber layers, which are now, you can measure them from OCT technology, essentially. So there's a whole bunch of Alzheimer's disease researchers. I think actually ANU would be a good place to do some of this work. I'm not sure whether you are involved in that, but they are really thinking about that. So the AMD, Alzheimer's disease, and the nerve fiber layer, that space is still quite open, actually. Yeah.
I have one.
Yeah.
So here in Canberra, we're having an emerging synergy between ACT Health
That's
system
right.
and the university.
Yeah.
If you had one or two tips for what you think would be the most important things for developing that.
Okay, so I think this is very important. I mean, I'll give you a few thoughts about this, because the first is that it's never going to be a simple, easy, and a partnership where you have one boss says everything can happen, all right? It's always complex relationships, which means that you're going to have a Ministry of Health, you're going to have a Ministry of Education, you're going to have hospitals, administrators, and you're going to have academic professors and deans, right? So I think realizing that that's how it is around the world. Doesn't matter whether you're in Singapore, where you have like one single prime minister for years, that kind of thing. It still doesn't matter, because it's still, when you come down to that level, everybody, it's you're individualistic. So I think accepting that is quite important. I was somewhat frustrated, I would say, maybe as a younger professor at eye and ear, where I found that it was very difficult to get my colleagues in the eye and ear hospitals, ophthalmologists, to be that keen, or the hospital CEO to be that keen about research, because you're thinking that it's important to you, but it's not important to them. As we become more senior, we realize that this kind of things, you can't force it. I think things like this, where you have everyone seeing the synergy that works, as well as the fact that a lot of the conversations are not happen over social events, it doesn't, you can't force teams together. You need to let a lot of the things happen on the ground that will build that kind of relationship. So I think, as I said, if you have this whole idea that everybody sees that there is some parts that they are interested in and some parts they are working in, and you look at the common things and you come together like this kind of meetings, that's what we did with some of the Academic Medicine Research Institute. Put some resources in, everybody put a little bit of resource. The university, the hospitals, it's not a lot of money actually, provide some biostatistical support and so forth. That allowed actually the environment to flourish much better than saying, let's have one single structure that everybody reports to this guy, and this guy will make sure everything happens. I think that doesn't happen. So I think that's probably the most important lesson, which means that everyone in this room, in one sense, has a part to play in that kind of relationship, right? The individual relationship, the relationship with your superiors, with your peers, with your students, and if you're able to understand that it's only by coming together that you're going to do better. And Canberra, as I said, I just looking at your logos and everywhere, and looking at the book, your program book, I think it's working essentially. Many places you only have the university type of setting, or you have the hospital setting, and that I don't think works that well.
Anything else? Any other questions? If not, I think we'll thank Tien for keeping the schedule and giving us a great talk. Thank you very much. I think we have a small break.
Thank you. Okay.